thing I'm going to show you here is I'm going to show you how we can look at aortic stenosis and how we sometimes have difficulties in really quantifying the degree and in making therapeutic decisions. This is a 70-year-old male who was hypertensive, aside from having aortic stenosis, and he developed actually significant dyspnea. So the question I'm going to ask you later on is, what condition do you think the patient actually has? But first I want to show you the images of the patient, okay? While I do this, what I really want to do is I want to just walk you through these images and show you what features I look at when I look at patients with aortic stenosis. The first thing in the parasternal long axis view is the degree of left ventricular hypertrophy. Now, the degree of hypertrophy is important because I've never seen a patient with severe aortic stenosis that does not have at least moderate left ventricular hypertrophy. So actually you can exclude severe aortic stenosis if no hypertrophy is present. But this does not mean that every patient who has severe hypertrophy has severe aortic stenosis, because remember, the patient can also have another cause of hypertrophy, as in this case, hypertension. So the next thing, okay, in this patient I would say his hypertrophy is pretty significant, so that would fit quite well to severe aortic stenosis. I hope you agree. I will then show you a 4-chamber view where you can see hypertrophy even better. And then the next thing I look at is the aortic valve. Okay, so I'm going to focus in on the aortic valve. And here I look at several things. The first thing is I look at the presence of a bicuspid valve. So doming, for example, which is not present here. And secondly, I look at the opening excursion of the aortic valve, as well as the degree of calcification. Maybe you can just make up your mind if you think that aortic stenosis is severe here, if the valve opens or not. I don't know how much experience each of you have in assessing the valve and determining the severity of aortic stenosis, but please do that. Now, I agree completely that you need Doppler to quantify the severity, but still, always look at the 2D image as well, and also look at the M mode. Now, this is the M mode through the aortic valve. What I'm using here is a pretty unique feature which is called anatomical M mode, which allows me to put the M mode ray through the position that I want to put it. It's kind of a reconstructed image. It's not, performing the M mode during the exam, but kind of reconstructing it from the image loops that I'm presenting. Here's the aortic root. You can see the motion, and at the same time you see the box of the aortic valve opening. Okay, so this is another bit of information I'm giving you. Here's again a zoom view of the aortic valve. But we do not only look at the aortic valve in a long axis, but it is even more important to look at the aortic valve in a short axis view. Here it is possible to see all the 3 cusps, and it's easier, or it's better to look at the aortic valve opening obviously in a short axis view. I'm going to show you several views of the aortic valve. Now there seems to be some degree of calcification and fibrosis here. Look at the motion of the cusps here. Now this is the color. Let me go back here. And again, we can put the anatomical M mode through here. And what I want to show you is that it depends very much on where you put this M mode ray through the aorta. Here you would have a fairly small box, which would mean there's not much opening. But if I move the cursor further to the middle, you will see that it starts to open, right? So this is the limitation of M mode. And this is also the reason why I don't think M mode alone is very good in quantifying the degree of stenosis. That's what we did, previously before we had 2D imaging. But nowadays, it's just a little helpful thing that you can use aside from 2D image. But it does work sometimes. Okay, Eleonora thinks that it seems to be severe aortic stenosis. Okay, I'm not going to comment on this on this point at this moment now because I'm going to ask that later to the rest of you. Now here is the short axis view, not an ideal short axis view, but it's the best I could get. You can see that left ventricular function is good. You have some degree of hypertrophy of the papillary muscles. But this view is probably much better in assessing left ventricular function and also septal thickness. Now I will just freeze this image and show you how thick the septum actually is. Okay, now it's 21 millimeters, which is a lot. Remember, normal we have 11, maybe 12, and even in many forms of severe aortic stenosis, you might only have 16, 17, and 21 is very, very much. So very severe left ventricular hypertrophy. There is only mild mitral regurgitation. You don't see very much flow convergence here. Okay. There is only mild tricuspid regurgitation. Oh yeah, something I wanted to show you. When you measure the thickness of the septum from an apical view, what I would always recommend is to use a bit of an atypical four-chamber view. A view where you kind of move the transducer more laterally, and thereby you have a better orientation to the septum. Remember, the septum should be horizontal, but in this case we don't want it to be horizontal. We want it to be a bit slanted because then we have a better delineation of the septal thickness. So this is usually better to measure the septal thickness than a classic four-chamber view. Okay, now we will go to the aortic valve, and we need to see if there's aortic regurgitation, because this is important, because the degree of the aortic regurgitation could be important when we then later look at the flow across the valve. And Simona is completely right. The most important thing we have to look at this point will then be the maximum velocity across the aortic valve. But just give me a second until I show you this, because what I personally do is when I have a patient with aortic stenosis, I do that last. The reason is that you kind of tend to forget to do the rest then, and the rest is very important as well. And all the things that you have to look at in these patients, like left ventricular hypertrophy, like the degree of aortic regurgitation, diastolic function, all these things could be forgotten if you focus immediately at the pathology that you're looking at. So here is diastolic function. You can see that we have a very tall E wave and a fairly small A wave. What you should appreciate, though, is that the A wave is probably this here. It's just this little part here, and this curve that we see is not really the A wave, but it's a so-called L wave. This is the phase. This wave occurs during the phase between the E and the A wave. It's during diastasis, and there we have a sign that the patient actually has elevated left atrial filling pressures. So we have a very tall E wave, a very small A wave, and an L wave. So it's clear that the patient has diastolic dysfunction, severe diastolic dysfunction, and severely elevated left ventricular filling pressures. How does that play out in this specific case? Well, it just shows us that the patient must have symptoms. It means that the left atrial pressure is high, and these left atrial pressures translate into the pulmonary circulation, and that is what basically causes pulmonary edema and signs of heart failure. So I truly believe the patient that he has symptoms. This is the proof of it. Now let's go on. Well, I don't think the patient really has atrial flutter. There seems to be just a very rapid motion of initial rapid motion of the mitral valve, simply because there is very much flow in the early diastolic phase. Now let me turn to the two-chamber view to see how left ventricular function is here. Again, function is reduced, and I would almost assume that it is even less in the inferior leads, in inferior wall. You have less contractility here. Compare this with this. So I would have the suspicion that the patient also has coronary artery disease. How would you all think that left ventricular function is? Well, I assume Most of you think it's abnormal. Well, I think so too. Okay, this is the two-chamber view, and now finally I'll come to the continuous wave Doppler signal. Okay, this is the signal, right? Here is the typical calculations you perform in patients with aortic stenosis. You trace the curve, oops, okay, like this. 2.4 meters, which calculates to a maximal gradient of 23 millimeters of mercury. We have a mean gradient of 12, or 13 if you round it up. Good. Now with this information, my question to you is, how severe do you think mitral aortic stenosis is? Okay, the possibilities are, do you think that the condition that is present is that of low flow, low gradient aortic stenosis? Do you think it's pseudo low flow, low gradient aortic stenosis? Or do you think it's paradox, low flow, low gradient aortic stenosis? Or paradox and pseudo low flow, low gradient aortic stenosis? I know I'm confusing you here, and it is sometimes very confusing, but I will show you later how we can easily separate these various conditions from each other. Yes, and the last question is, do you think that aortic stenosis is not severe at all and that it's only moderate, and that the patient has hypertensive heart disease and that that is actually his main problem? Okay. Well, a number of you think that it is low flow, low gradient aortic stenosis, which is a good choice. It's a good choice because you notice that the patient has reduced left ventricular function. So patients with a reduction in left ventricular function can usually not put up such high gradients, and that is the reason that the gradient is not high. And truly left ventricular function is not normal in this patient. Now, the other issue, of course, is could it be pseudo low flow, low gradient aortic stenosis? What is pseudo low flow, low gradient aortic stenosis? Well, it is a condition where you have normal ejection fraction, but you still have low gradients, and these low gradients are caused by usually having a very small ventricle, where patients have normal ejection fraction, but still reduction in flow across the aortic valve, and that is the cause of the relatively low gradients. Now, if you look at the absolute velocities here, you will see that the velocities are not very high. Usually, to have severe aortic stenosis in the setting of low flow, low gradient aortic stenosis, you would have to have velocities of at least 3 meters per second. So it's kind of unusual to have any of the conditions, pseudo low flow or low flow, low gradient aortic stenosis in this setting. But we still went on to perform another test to clarify this, and I'm sure you all know which test that would be. That is stress echocardiography. Now let me go to the findings of stress echocardiography. Or let me first explain you what is done here. Well, we put the patient on a bed and we give him dobutamine, and we increase the dose of dobutamine, and while we do this, we record the echocardiogram. We perform both 2D images, and at the same time we also perform calculations of flow and gradients. And what you see here is the resting 4-chamber view, and then we increase the dose, and here we have 5 micrograms of dobutamine. You can see how his left ventricular function is starting to get better. Now this is 20 micrograms, and you see how his left ventricular function is improving even more. And then finally we have a maximal dose of 15, and this is his function now. Now the object here is to increase left ventricular function to an extent that we are able to generate enough flow to kind of unmask severe aortic stenosis. This, of course, only works if we can stimulate the patient and if there is some form of contractile reserve, if the patient has a ventricle which is completely kaput, as we say here, then we are not able to generate gradients, and then we can just simply not come to a conclusion with the test. Let me go now to the study again, and I will compare the different 4-chamber views so that you can see how much ejection fraction has actually changed in this patient. Okay, let me just find the right loops. Okay, so these are the four chamber views. This is rest, this is low dose, higher dose, and maximal dose. If you compare the two, you see that there is a contractile reserve. Ejection fraction, beyond doubt, is better. And the question now is, how does that influence the gradients? So I will now go to the different continuous wave Doppler signals. Just have to find the right ones here. And this is the last one. Okay. So those are the 4 tracings across the aortic valve. We started out with a velocity of maybe 2-point-something meters, which got a bit higher, 3 meters, and at peak velocity, we came to a maximum velocity of maybe 3.3 meters. I think there was a tracing where it was a bit higher. So despite the patient having an increase in contractility, we did not get very much additional gradients. So let me now go back to my slide presentation and show you the values, okay, which you cannot see for some reason. In any case, it does not make a difference. It's not important. The point I'm trying to make here is that the patient did not have a significant increase in the gradients, and that his aortic valve area increased from 0.6 to, I think it was 1.2, and that this is a sign that the patient does not have significant aortic stenosis. There is another thing that you can use in such patients, or at least in patients who do not exhibit an increase in contractility. You can kind of project how the aortic valve area would change in the setting of normal contractility, and this formula that we can use is shown here, and it helps us to calculate the so-called projected aortic valve area. And if you have a high projected aortic valve area, as in this patient, that would denote that the patient does not have severe aortic stenosis. If you have severe aortic stenosis, the opening area would still be below 1 centimeters squared. So this is something that you can do in these patients. But I think if you are very sharp, you already note from the 2D images that this is probably not severe aortic stenosis. One of the most important findings, in my view, is that of a very early peak. If you have a very early peak, that speaks very much against the presence of severe aortic stenosis. Okay? And the other issue that we have here is that the patient has overproportional left ventricular hypertrophy. So I think in his case, the main problem is that he has a damaged ventricle caused by hypertension, probably also coronary artery disease, as we later found out he did have through vessel disease, and that is his main problem, and not so much aortic stenosis. Sure, aortic stenosis, as we think it is mild or maybe mild to moderate, plays an additional role, but it is probably not his main problem. And this information is very important because I do not think that he would benefit from aortic valve replacement.